Bismillahirrahmanirrahim. Assalamu alaikum and hi my friends. As we have started the series of eye, and in the previous lectures we have started the lacrimal system. In the lacrimal system we have discussed the diseases of the drainage system or excretory system. Now in this lecture we will start the diseases of the secretory system of the tears. Okay, so the lacrimal system, mainly the lacrimal gland. The lacrimal gland is situated in the roof of the orbit in the superior lateral region, in the fossa, which is called the lacrimal fossa. The first disease is the acute dacryoadenitis, the second one is chronic dacryoadenitis, and the third one is the keratoconjunctivitis sicca, which is also called dry eye syndrome. So what is acute dacryoadenitis? It is basically the acute inflammation of the lacrimal gland. And the main bacteria which are involved in the infection and inflammation of the lacrimal gland in acute dacryoadenitis, they are SSG. SSG mean Staphylococcus, Streptococcus and Gonococcus. These are the main bacteria which are involved in the infection of the lacrimal gland. Sign and symptoms. How the patient will present? The patient will present with redness and edema of the lid margin. So the lid margin will be edematous red, okay? And the lid margin, the shape of the lid margin, it will become S shape. For example, like this. The upper lid margin, they will become an S shape structure like this, okay? Because of the inflammation, due to this all region will be inflamed, and it will induce an S-shaped margin of the upper eyelid. And eye is pushed downward and inward. There will be proptosis. This lacrimal gland when swollen, it will push the eye downward and inward. This is called this is called proptosis, and the proptosis will be painful. Okay. The next one is the restriction of eye. The eye movement will be restricted in as the lacrimal gland. This gland is swollen, so this will restrict the movements of the eye to the upward direction and to the outward direction. To the upward and outward direction, the movement of eye will be restricted. The eye will be pushed in the downward and inward direction, and its movement will be restricted in the upward and outward direction. Okay? And there will be pain and discomfort in the outer region. In the outer upper region, there will be extreme pain and discomfortness in the acute dacryoadenitis. These are the signs and symptoms. Okay. Now what are the treatment options? One thing. If the condition is not managed timely, then there can be the formation of abscess. Okay. The abscess can develop in the acute inflammation of the lacrimal gland. The treatment option we have as it is the acute infection, so antibiotic, for example, topical and systemic antibiotics are advised. Analgesic, as there is extreme pain and tenderness, so analgesic will be prescribed. And warm compression is also helpful because warm compression will resolve the inflammation and has also a soothing effect. Okay. Incision and drainage. If the abscess has developed, then we will incise and drain the abscess. This is acute dacryoadenitis. Now the chronic dacryoadenitis, if the lacrimal gland, there is the inflammation which is chronic. Why the chronic inflammation has developed in the lacrimal gland? Okay, the chronic dacryoadenitis is mainly an inflammatory and autoimmune condition. Etiologies: the chronic dacryoadenitis is caused by leukemias, it can be caused by lymphomas, tumor infiltration can cause dacryoadenitis chronic, sarcoidosis can cause, tuberculosis can cause chronic dacryoadenitis, syphilis can cause chronic inflammation of the lacrimal gland, and amyloidosis can also cause chronic inflammation of the lacrimal gland. So these are some of the etiologies of the chronic dacryoadenitis. The signs and symptoms of the acute and chronic dacryoadenitis, they are similar, except that there will be the redness and edema. Okay, in the lid margin there will be S-shaped lid margin. There will be restriction, there will be proptosis in the downward position, there will be restriction of movements of the eye in the upward and outward direction, but the pain and discomfort will be absent. In the chronic dacryoadenitis, there will be no pain and discomfortness. Most of the symptoms are similar except the pain and discomfortment, which is not present in chronic dacryoadenitis. Okay, and these are the main etiologies of the chronic dacryoadenitis. The treatment option of chronic dacryoadenitis depends on the underlying cause. If this is leukemia, lymphoma, sarcoidosis, TB, syphilis, so when we treat these underlying causes, it will also treat the condition. The third secretory disease of the lacrimal system is the Keratoconjunctivitis Sicca, which is also called dry eye syndrome. What is happening in this condition? There is insufficient production of the aqueous part of the tears. We know that the tear is composed of three parts: the mucinous part, the aqueous part, which is about 90%, and the lipid part, which is the outermost part. So when there is any problem with the aqueous part, when the lacrimal gland does not produce the aqueous part sufficiently, it will be called Keratoconjunctivitis Sicca or dry eye syndrome. Or there is another definition in which there is problem with the aqueous part of the tear, okay, or there is problem with the lipid part. When the lipid part is it is not normal, there is problem with the lipid part, so the aqueous part will also evaporate rapidly, and it will cause the condition of unstable tear film, which is called Keratoconjunctivitis Sicca. So when there is problem with the aqueous part or the lipid part, it will cause Keratoconjunctivitis Sicca. What causes the problem with the aqueous part of the tears? The first one is the pure Keratoconjunctivitis Sicca. In pure Keratoconjunctivitis Sicca, the only problem is with the lacrimal gland itself. Okay, so the only problem is with the lacrimal gland. The problem in the lacrimal gland is caused by, for example, congenital alacrima. Congenital alacrima means that a child born without lacrimal gland. The second is the denervation hyposecretion. So when the lacrimal nerve is damaged, so the secretion will also be will be reduced. And idiopathic, we don't know why the lacrimal gland is insufficiently producing the aqueous part. So the third condition is idiopathic, we don't know the cause. So this is the pure Keratoconjunctivitis Sicca. The only problem is with the lacrimal gland. It can be alacrima, it can be denervation hyposecretion, or it can be idiopathic hyposecretion. Okay. The second cause of the aqueous deficiency is the primary and secondary Sjögren syndrome. Sjögren syndrome is an autoimmune condition in which multiple parts of the body they are affected. So in the Sjögren syndrome, the lacrimal glands and the salivary glands are also affecting. Okay, so it will in the primary Sjögren syndrome only the salivary gland and the lacrimal gland, they will be affected. Okay, so they will be affected. This is the primary Sjögren syndrome. And secondary Sjögren syndrome, the lacrimal gland and the salivary gland both will be affected, but they will also be associated with some systemic autoimmune diseases. For example, systemic SLE, rheumatoid arthritis. So when it is associated with systemic manifestation, it will be called secondary Sjögren syndrome. The third one is the non-Sjögren causes, non-Sjögren syndrome causes. It can be TB. TB can affect the lacrimal gland. Sarcoidosis can affect the lacrimal gland. Amyloidosis, leukemias, lymphomas, etc. They can all can affect the lacrimal gland and can induce the hyposecretion. Okay. Now this was about that. These were the causes of the why the aqueous part is not producing sufficiently. Now, what are the causes of evaporative disorder? What are the causes which causes an unstable lipid layer over the tear film? This is the meibomian gland dysfunction, and we have discussed in the previous lectures in detail the posterior blepharitis. In posterior blepharitis, there is the dysfunction of the meibomian gland. The meibomian gland is present in the eyelid, which produces the oily secretion. Okay, and keep the tear film stable. by putting in a lipid layer over the aqueous part. Okay, so this is about the aqueous deficiency and evaporative disorder and the pathogenesis of the Keratoconjunctivitis Sicca or dry eye syndrome. So what are the signs and symptoms? There will be the burning sensation, there will be photophobia, irritation. These all conditions, the burning, photophobia, irritation, they will be worsened by the windy, hot and dry environment. Because the tear film is already the tear film, it is unstable. And when someone goes into the windy and hot and dry environment, it will further increase the evaporation of tears and it will dry the conjunctival and the corneal surfaces. Okay, so the burning, photophobia, irritation, it will be further increased by these factors. The photophobia is caused by the punctate epithelial keratopathy. Punctate epithelial keratopathy is, it will be the dead and devitalized epithelial cells of the cornea, and this dead and devitalized epithelial cells, it is due to the unstable tear film. Okay, and mucous strands will be formed. As we noted, the lipid part is unstable and the aqueous part is evaporated because of this instability. So we only be left with the mucinous part. So the mucinous part is dry. So the mucinous part will form strands of the mucus. The mucus strands will be formed because of the dry conditions. And the corneal epithelial filaments. As we discussed previously, that the dead and devitalized epithelial cells. These epithelial cells, they are present dispersely. Okay, so when, for example, this is the corneal, this is the corneal mucus strands. Okay, these mucus strands, these devitalized and dead epithelial cells will surround these mucus strands like this. They will surround these mucus strands like this. This is called corneal epithelial filaments. When someone is blinking with these corneal epithelial filaments, with blinking it will produce pain, because with blinking these filaments will move like this and with the lid margin and will irritate the corneal and conjunctival surface and will produce pain. So burning, photophobia, irritation. Photophobia is caused by punctate epithelial keratopathy. There will be the formation of the mucus strands. There will be the corneal epithelial filaments. These all are the signs and symptoms of the Keratoconjunctivitis Sicca. Now, how to diagnose the Keratoconjunctivitis Sicca? We can diagnose the Keratoconjunctivitis Sicca or dry eye syndrome through various methods. For example, we can use stents, different types of stents such as the rose bengal stent, lissamine stent and fluorescein stents. These stents, they will stent these dead and devitalized epithelial cells, these mucous strands and these corneal epithelial filaments. They will stent this and will tell us the severity of the Keratoconjunctivitis Sicca and dry eye syndrome. Okay. The next test is the tear film breakup time. What it means by the tear film breakup time? It means when someone blinks, so after blinking, the existing tear film disappear after about 15 to 20 seconds normally. But when someone has Keratoconjunctivitis Sicca, this tear film breakup time will be reduced from below 10 seconds. So the normal tear film breakup time is 15 to 20 seconds after the blinking. But in Keratoconjunctivitis Sicca, the tear film breakup time will be reduced less than 10 seconds. Okay. The next test and the most sensitive test is the Schremer test. What are we doing in the Schremer test? First of all, we will take a Whitman filter paper of size 535. Okay, we will take the paper. Okay, the next step, we will fold the paper. We will fold the paper like this, and we will place in the conjunctiva. We will place in the conjunctiva of the patient like this. We will place in the conjunctiva, and we will advise the patient to close his eyes gently. Okay. The next step is when, after about 5 minutes, when he closed his eyes, we will wait for 5 minutes. So after 5 minutes, we will look to the Whitman filter paper. If its reading is ready, if without anesthesia, without anesthesia, if the wetting is less than 10 millimeter, then it will be a diagnostic of keratoconjunctivitis sicca. And with anesthesia, when we with local anesthesia, when the wetting is less than 10 millimeter, it will be considered keratoconjunctivitis sicca. So without anesthesia, less than 6 millimeter. With anesthesia, less than 10 millimeter of wetting will be considered keratoconjunctivitis sicca of Whiteman filter paper. Okay. So these were the diagnostic methods of the keratoconjunctivitis sicca. The treatment options can be conservative and surgical. The conservative treatment options, they are the artificial tears, gels and ointments. Okay, for example, the cellulose derivatives, the polyvinyl alcohol, and for example the petroleum mineral oils. So these they are the mainstay of treatment in dry eye syndrome. Okay, the mainstay of treatment is the artificial tears, gels and ointments. We can use the autologous serum. Autologous serum contains growth factors and vitamin A. So these dead epithelial cells are when they are about to die. So this autologous serum contains growth factors and vitamin A, which will protect these cells. The next is the mucolytic agents. For example, we will use 5% acetylcysteine, and we know that when there are multiple corneal filaments, so they are present, the mucous strand will stick together and they will form, the mucus will stick together and it will form corneal filaments. So for the breakdowning of these corneal filaments, we will use mucolytic agents. And the next is vitamin A. As we know that vitamin A is protecting us from the autoimmune condition, from inflammatory condition, from free radical, etc. So vitamin A is beneficial in keratoconjunctivitis sicca. And we can also use anti-inflammatory agents, for example, NSAIDs, topical NSAIDs, steroids, cyclosporine, etc. They will act as an anti-inflammatory and will protect this injury to the eye. These all are the conservative treatments. Okay, tears, autologous serum, mucolytic agents, vitamin A, anti-inflammatory. The surgical treatment is, we have mainly three types of surgical treatments in the keratoconjunctivitis sicca. Number one is the punctal plugs. In punctal plugs, we know that in the lacrimal, there are the lacrimal punctum. Okay, so we will plug the lacrimal punctum. When we plug the lacrimal punctum, it will be closed. When they are closed, so the tear will not be drained, and there will be the retention of tears, and it will keep the tear film stable, and it will moist the eye. Okay, and will reduce the injury. So the punctal plugs. Cauterization is another method. We will permanently close these by electric cautery, by burning. Okay, by electric cautery and burning, we will permanently close these punctum, so the tears will accumulate and it will keep the eye, the corneal and conjunctival surface moist and protected. Okay, and then the last is the parotid duct transplantation. And parotid duct, we know that the parotid ducts comes into the mouth. Okay, and from the mouth we can transplant this parotid duct into the eye. So from the secretion, the tears, the secretion of the parotid duct will come into the eye and will keep the eye moist and protected. So these are the surgical options: the punctal plugs, the electric cauterization, and the parotid duct transplantation.